Today we will be presenting on the feasibility of the lower extremity Fugl assessment in acute stroke. My name is Paige Sen, and I also worked with researchers Leah Vrujink and Delaney McNeil with our faculty advisor, Dr. Victoria Pardo. The Fugl is used to assess motor recovery in patients following a stroke. We specifically researched the Fugl lower extremity, which assesses reflexes, active movements, and coordination of the lower extremities in a variety of positions, including supine, side-lying, sitting, and standing, to determine motor recovery in patients following a stroke. Previous research groups looked into feasibility of administering the FMA lower extremity in the clinic based on factors such as reliability, time to administer, and physiological effects on patients. We followed this study and did a detailed item analysis on inter-rater reliability, discrepancies between the final scores during Trial 1 and Trial 2, discrepancies within the FMA lower extremity, and which sections produced the most inconsistencies between raters. Our participants were recruited from the inpatient unit at the Rehabilitation Institute of Michigan in Detroit. Inclusion criteria were as follows: acute stroke, 18 years of age or older, ability to follow two-step commands, and full weight bearing on both lower extremities. Patients who were medically unstable, had a bilateral stroke, or lower extremity amputation were excluded from the study. There were 3 roles during each trial, which included assessor, silent observer, and blinded experimenter. The assessor performed and rated the FMA lower extremity. The silent observer was in the room quietly rating and timing the assessment, and the blinded rater was in the hallway throughout the assessment. The data was analyzed and stored using SPSS. The MDC-95 was calculated using Z equals 1.96, which represents the threshold for real change in physical performance at the 95% confidence interval, meaning we are 95% confident the changes observed were not the result of measurement error. Finally, the statistical significance was set at p is less than 0.05. In row 1 on this table, it summarizes trial number 1, which compares the FMA lower extremity scores between the assessor and silent observer. The mean score between the two was found to be 22.88 with an ICC of 0.99, demonstrating extremely high inter-rater reliability, and the MDC-95 was calculated to be 1.58 units. In row 2, the information represents the scores between the 2 different assessors during the 2 different trials. The MDC-95 was found to be 3.66, meaning there must be a change in a patient's score of at least 4 to demonstrate that there is actual motor recovery and the change is not due to measurement error. This is a graph to represent the discrepancies between the 2 raters in Trial 1 and Trial 2. We found that the largest discrepancies were patients who scored between 20 and 25 points, followed by patients who scored between 19 and 15 points. Those who scored higher and those who scored in the lower end had the least number of discrepancies. This may be due to it being more obvious that they were very successful or unsuccessful in completing the tasks. We also analyzed each item on the FMA lower extremity and what sections showed the greatest inconsistencies. The first section included reflexes, the second section examined a flexor synergy, the third section examined an extensor synergy, the fourth section examined movements combining synergies, the fifth section looked at movement out of synergies, the sixth section tested the patient's reflexes, and finally, the seventh section tested the patient's coordination. Our data concluded that 3A had the most discrepancies of 10, followed by 3B and 3D with 9 discrepancies each. In reference to the chart on the previous slide, we found the greatest inconsistencies were in Section 3, the extensor synergy portion. In 3A, the therapist must feel if the patient is adducting their leg, and the silent observer is unable to feel this. They will have a hard time knowing if the patient is doing adduction to rate them properly. Similarly, with hip extension, 3B, and plantar flexion, 3D. This measure wouldn't be ideal if someone was looking to score via video because some things you need to feel rather than just see. The previous study found that the FMA lower extremity required less than 10 minutes to administer and was a well-tolerated assessment among the acute stroke population. An ICC of 0.99 demonstrated a high inter-rater reliability between the 2 assessors. Clinically, this means it may serve to be a good, reliable outcome measure when used by different clinicians. A change of 4 or higher demonstrates the change in score has likely occurred due to motor recovery and not measurement error. After examining the results of the study, we discovered that the patients who scored very high or very low showed less discrepancies between the raters. The section with the most discrepancies was Section 3, which examined the extensor synergy. As mentioned previously, it may have been difficult for the silent observer to assess the patient's hip extension, adduction, and/or plantar flexion without actually feeling it. In summary, the Fugl lower extremity is a valid, reliable, and feasible tool to utilize clinically in order to assess motor recovery following a stroke. Thank you, and here are our references.